Waiting,
Okay.
sir.
Okay. So, good evening and warm welcome to everybody. A warm welcome to today's faculty, Dr. Rajesh Taneja, who will be talking about bladder pain syndrome and interstitial cystitis. To have the opening remarks and the opening of the today's virtual learning for the residents, may invite Dr. Rajiv Sood, Chairman of Indian School of Urology, USI, for his comments and opening the today's class. Over to you, sir.
Thank you, Dr. Arun Chavla. This is a great time going on when we are in the final lectures of our distant learning program, resident learning program, and today we have very eminent teacher, that is Dr. Rajesh Taneja. He is from Apollo Hospital. He was in PSRI before. He was in many other eminent centers, and he was in AIMS. He did his MCH, and in all this journey, he developed a special interest in interstitial cystitis, bladder pain syndrome, and also Holmium laser. He was one of the pioneers, and also robotic surgery. So coming back to today's topic, which is bladder pain syndrome or interstitial cystitis. This is a topic which is very important for theory. It is very important as the dilemmas in the investigations and also managements of the patients in the urological clinics and also in the gynecological clinics. And Dr. Rajesh Taneja has authored books on this. He has authored chapters on this, and he is expert. He's in making the guidelines also for this situation. This has been defined as the rare disease, not rare because of the occurrence, but because of the diagnosis, reality, and also the treatment problems. And we have been facing this dilemma of managing and treating, and this is compounded with the ever-changing definitions of interstitial cystitis or the bladder pain syndrome, their overlapping nature, or they are separate entities, how the International Continent Society is dealing with this, and how the management concepts, diagnostic uh, parameters, they keep on changing. So today, for the residents, it is a great time. That great teacher is with you, great with plenty full of knowledge, and also he is going to share all his experience and also the requirements of the MCH DNB curriculum, and also the practical tips for the um, your clinics, and also theory papers, and also in the viva, which you are going to face in your final exams also. And in this endeavor, we will be having interactive lecture by Dr. Rajesh Taneja. And with this all brief introduction, I open this class for presentation to you, all the residents and young urologists. And let us hear Dr. Rajesh Taneja. Welcome, Dr. Rajesh Taneja, for this class, and welcome all the delegates, all the residents.
Thank you,
Dr.
Dr. Rajiv Sood and Dr. Arun Chavla, for the kind introduction. So, of course, this is a disease which was initially thought that it does not exist in India. And when I was getting trained in All India Institute
Dr.
in the
Rajesh,
1991,
Dr. Rajesh,
94, we
can,
were taught, yes, yes,
Dr. Rajesh, can you give me 1 minute?
yes,
Let me invite the
yes,
two
sir.
residents. Yeah.
Okay.
Prashant Yadav and Shruti Pandit, if you can keep your uh, audio and video on so that Dr. Rajesh Taneja can interact with you in the case discussion, which is going to follow after initial 5 or 6 slides. Yeah. are you on? Shruti and
Yes, yes,
Prashant
Sir, sir.
Yadav,
yes,
can you say yes?
yes.
Okay,
Yes, sir. Yes, sir.
okay. Yeah, okay, okay. Welcome to today's class. Okay, and Dr. Rajesh, you are seeing them. They are pinned their. We have pinned their
Yes.
video. You can see them. And
So
whenever,
I
when,
would
yeah. So
so I
names
would
are
like
Prashant
to
and yeah,
so
two
I would
names.
like to know they are the MCH residents from teaching institutions.
Sir,
Yes,
I'm the
the
MC.
go ahead, go ahead.
Sir, I'm Dr. Shruti Pandit, MCH resident from KMC Manipal, sir.
Okay,
And
good. And you are
so myself,
MS General Secretary before that.
Yes, sir. It's from Manipal itself, sir.
Okay, yeah. And
so
Dr.
myself, Dr. Prashant
Prashant.
Yadav from Safdarjung Hospitals.
Okay, so you are also an MCH resident.
Sir. Third year residency.
Oh, third year resident. So good. So welcome to this interactive session. And the
So thank
idea
you.
is to stimulate you people to go back and read about it. I cannot teach the whole subject in 1.5 hours, and I do not expect you to answer all the questions that I may be asking. The idea of asking questions is to stimulate you to go back and read so that you have a concept. What happens is that when you read only theory, you tend to get lost. You don't know what to focus on and what to uh, imbibe. But when we go on as a case discussion, you will really understand why each question is important that I ask. So when I was a trainee like you in 1991, I was taught that this does not exist in India, and it was thought that it is a dumping diagnosis. And these patients, but when I came into practice in 1994, after finishing my MCH, I was on my own, and I used to see these patients who used to see multiple doctors with years of suffering. Somebody had got a prostatectomy, other had got a hysterectomy. There was no way, there was no set pattern how people were being treated. And when I was a resident, my senior resident, when I was a first year resident, the third year resident told me it is FDS, frequency dysuria syndrome. And there was no clue what is FDS or frequency dysuria syndrome or just a urethritis. And there were patients who would come, and if you listen to them, they had suicidal thoughts. So when all these things were happening and I was on my own, I thought this is a subject that needs to be looked at, because what happens is your eyes will see what your mind knows. If your mind doesn't know, your eyes will not see. So it is actually a very bad quality of life. It is poorer than CKD on maintenance hemodialysis. So that is the level of quality of life of these patients. So I start with this small case. So this is how this lady would present. She's a 39-year-old lady. I think there is somebody who needs to mute his mic. Is the USI office around? Is the USI office around? There is
Navneet,
somebody.
background noise is there. Navneet from Navneet, background noise is there from somewhere. Please see.
Hello. Yes. So am I audible? Can I continue?
Please
Yes.
go ahead, sir.
Okay.
Go
Yes.
ahead.
So we see this lady. She's a 39-year-old lady who has a 4-year history with episodes of frequency, dysuria, and pain lower abdomen and urethra. And she has been treated with antibiotics by the local gynecologist over and over again as UTI. And when she comes to your clinic, she says, I have recurrent UTI, I have persistent UTI. In my part of the city where I work, people talk in English and they take pride in talking into technical language. So they say UTI, मुझे UTI हो गया है, UTI ठीक नहीं हो रहा है. Because everybody has taught these patients that you have a UTI which does not go. And if you look at the urine routine, there was only 0 to 4 pus cells at the most, and the cultures were occasionally positive. But despite the fact that there were no pus cells or no urine culture positive, she was given antibiotics. There were periods where these episodes were completely silent. She was absolutely fine in between. And especially when she had her second pregnancy, she was completely free of symptoms for 14 months. So, my question to you, Dr. Shruti, is
Yes, sir.
uh, is that you have this patient who presents like this. Would you like to ask some more questions?
Um,
Or what
so first I
questions
would
would
like
you
to
like to ask this patient?
First, I would like to characterize the symptomology. Is she having pain which she is specifically describing to the bladder? Is it associated with the full bladder? That would Is it associated with any other associated complaints like pain elsewhere radiating to the groin? Then I would like to rule out certain obvious causes of frequency dysuria. Look for any obvious urinary tract infection which she doesn't have, sir. Mm, uh,
Anything else, Dr. Prashant, would you like to ask? So, Shruti, you have actually covered very nicely a lot of things. And the most important characteristic thing in case of pain is that if the pain is being relieved on passing urine, then perhaps we are dealing with something like bladder pain syndrome. The other
yes.
things that we need to talk about is frequency when it comes to frequency. So when she's sleeping at night, does she wake up from sleep or not? Some people will have compulsive voiding dysfunction where they would keep going to the washroom when they are awake. But once they sleep, say for 6 to 8 hours, they just may not wake up at all and they wake up in the morning. So this is a functional kind of a persistent desire to pass urine, which is relieved on passing urine. So, but then they get uncomfortable if they don't pass urine. Another question that I would like this patient to answer to me is that if you are waking up at night to pass urine, are you waking up with pain or are you waking up with a full bladder? More often than not, in bladder pain syndrome, they would wake up with a pain sensation. So they are scared to sleep. They say that if I go to sleep, I wake up with an intense pain because the bladder is bursting full. So that is another question that we have to say. One more question here while we are on the history is that when she says that I have a lot of frequent desire to pass urine, then I generally ask this question. So you are sitting here and suppose you have a desire to pass urine and there is no washroom around. So what are you scared about? Are you scared about the fact that you will become uncomfortable or you will have pain or you are scared because you may just leak? So if she says, I'm scared because I may just leak, that means we are looking at something like an overactive bladder. And if she says, I'm scared because it will cause pain and I won't be able to bear it, that means we are looking at a bladder pain syndrome. So these are the 2, 3 questions which will differentiate similar symptomatology in this kind of a woman. So you're absolutely right. We need to characterize the description of pain. Then there is a question of duration. We need to have more than 3 months duration. So if you look at the other guidelines, the American guidelines talk of 6 months duration. The ESIC guidelines do not talk about duration at all. We decided to have a 3 months duration because I think if somebody has been persistently having a symptomatology of more than 3 months, it is reasonable for us to suspect a bladder pain syndrome. And you have just talked about which is worst on full bladder. So there is no age group which is excluded. There was a time when NIDDK criteria in 1987 were furnished. They said that the exclusion criteria was if the patient was less than 18 years of age. But nowadays we know we have children with bladder pain syndrome. So we really do not know whether we have whether we were correct then or we are correct now, but we do come across bladder pain syndrome less than 10 years. There are series published in pediatric urology journals. Coming to the urinary symptoms, I have just talked about the frequency, urgency, dysuria. Now, coming to dysuria, that is burning sensation. So, when the patient says burning sensation, we need to qualify it further. Whether the burning sensation is at rest, that means I will ask her, do you have burning sensation while you're sitting with me here? If she says, yes, I have a burning sensation even now, that means she has a vaginitis, she has a urethritis and vulvitis. So there's an inflammatory pathology in the vulva, and while she's sitting, she has a burning sensation. Then she says, okay, I don't have a burning sensation now, but I have just passed urine, and I will start having burning sensation after some time. That means this is bladder pain syndrome. So the burning sensation had disappeared when she passed urine, but it starts filling up. The bladder starts filling up, and the burning sensation starts coming up. That means this is a bladder pain syndrome. Then suppose she says, I don't have burning till I start passing urine. So the bladder is full. She has a desire to pass urine. There is no pain, no burning, but she goes to the washroom. She starts passing urine and the burning starts. This is urethritis. Suppose she says, I start passing urine. Initially, there is no burning, but towards the end, the burning starts and it stays on for 10 minutes after I have finished urination. This is again vaginitis because the acid in the urine is coming in contact with the vaginal wall and is causing burning sensation. So this means, so you have to differentiate dysuria, which is just like a burning sensation while passing urine, and you have to dissect it into these four columns. If you can do that, you will localize the disease or the site of pathology. Coming to pain, yeah, pain and heaviness and pressure, these are three different terms which are used to describe the discomfort that occurs with a full bladder. Everybody may not call it pain. Some people will call it heaviness. In North India, they will call नलों में दर्द होता है, फिर मैं चली जाती हूँ वॉशरूम. बिहार से जो आता है वो होता है पेड़ू में दर्द होता है, पेड़ू भर जाता है. So these are the local colloquial terms which we must be aware of because our patients do not come and talk in English. So this pain that we are talking about, which originates from the bladder, can go into all these places: lower abdomen, perineum, vulva, clitoris, penis, inner thighs, lower back, and anus. And as we have just talked about, how is it related to micturition cycle, I've just dissected. Then the question of dyspareunia. Now, there is dyspareunia can be a superficial dyspareunia or deep dyspareunia. If it is a superficial dyspareunia, then it means that there is a there is a pathology in the introitus or in the vaginal epithelium. And if it is a deep dyspareunia, that means there is a depth, there's a disease inside the pelvis. And it is the deep dyspareunia which is associated with bladder pain syndrome. If it is superficial, then perhaps we are looking at a local pathology. Painful ejaculation can be seen both in chronic prostatitis as well as in interstitial cystitis or bladder pain syndrome. We must ask about confusable diseases in the history, for example, prior pelvic surgery. So sometimes people would have had a bad surgical procedure, maybe because of a burst appendix or diverticulitis or PID, and then these infected surgical wounds would heal with scarring and tethering of bladder. So if there is a tethered bladder, say tethered to, especially it occurs when there is tuberculosis of the pelvis, which is now getting rarer. But if there was something that was operated upon and there was extensive cicatrization, then the bladder would get stuck with some part, and as it would fill, it will cause pain, and that would present as bladder pain syndrome. But one needs to look at all that related to the previous surgery, look at the scars, and see how things are. Pelvic radiation causing radiation cystitis is again a very close differential. In fact, it is the same thing. There is a pan inflammation of the bladder, all the layers of the bladder, and therefore it presents mimics. So if sometimes people do not give you history, you have to find out what went wrong, because radiation cystitis can present even after 2 decades of the last radiation dose. Somebody who has been treated for infertility means there must have been some pelvic inflammatory disease or endometriosis, which could also give rise to pain while the bladder is getting filled. And that is because it causes a restrictive kind of a lesion around the bladder. So whenever the bladder is trying to distend, there is a stretching of that area, that lesion, and that is causing pain. One must exclude a neurological disease if there is a voiding dysfunction. So one has to be clear about taking that kind of history. So when we talk of etiology, because there are so many things that could have gone wrong, so we generally ask about history of allergies, bronchial asthma, seasonal hay fever, drug allergies, urticaria, because if somebody has atopic kind of a physiology, that means there may be an allergic reaction to the metabolites of the food or something that the person is taking, and that is getting stored in the bladder. So the site of urticaria could be the bladder itself. So there is, if somebody has history of allergies, that means we can make out and we can think that okay, this is the patient who may have an allergic phenomena to either one of the constituents of urine, and perhaps we should be trying some anti-allergic treatment. We will come to it in the subsequent slides. If there is history of obstructive symptoms, it could be due to pelvic floor spasm or something called overactive pelvic floor. And overactive pelvic floor causes dysfunctional voiding in adults. And people with interstitial cystitis or bladder pain syndrome, various series have reported up to 85% in some series that these women had dysfunctional voiding due to overactive pelvic floor, and that was the cause of all her symptoms. So one has to be very careful. In men, one has to exclude obstruction due to stricture or prostatic enlargement. History of burning characters. Now, this is the typical description given by the patient, is that there's a pinprick sensation as the bladder fills, and the pinprick sensation is around the clitoris because that's the most sensitive part of the body. So as the bladder fills, the clitoris has pricking sensation unless she goes and pass urine. So this is suggestive of neuropathic pain. Whenever there is a pinprick sensation, it is usually a neuropathic pain. And if there is neuropathic pain, one needs to look at a kind of treatment which would be effective in neurological diseases like tryptomar, because neuropathy, or gabapentin. So this is how you get a clue from the history how to treat these patients. Then there could be a recent change in diet. So during Corona, a lot of people were taking kadhas or decoctions, and then these patients, they had accentuation of their symptoms if they were already having bladder pain syndrome, or a lot of de novo bladder pain syndromes appeared in the month of July, August, because they have been taking kada for 3-4 months. So somebody suggested them to take 1 glass of kada, and they were taking 3 glasses of kada, and they were taking all kind of bladder irritants, because all these things are excreted in the urine, and they are excreted, they are accentuated in the acidic media. So that is how they would cause some kind of inflammation, because the bladder is finally storing these metabolites. excessive green tea, black coffee, dark chocolates, and these all can trigger not only overactive bladder but can also cause bladder pain syndrome. One has to be very careful in asking whether somebody has started something else. So somebody who is not used to putting a particular ingredient in a tea, cup of tea, has started putting that in tea, that's a very simple thing to ask. And but it takes time. You have to take a detailed history to find out something suggestive of etiology. The problem is that the bladder pain syndrome is a heterogeneous group, and unless we dissect out the various subgroups, the treatment will not work. The moment we accept that it is a heterogeneous group, we should accept that one treatment is not going to work in all these patients. So we need to identify which group of patients will be benefited by which group of medicines. Sometimes simple change in the drug can give rise to, for example, the glycosyloric drugs, which are being used for diabetes these days. So they have a very high concentration of sugar in the bladder. These patients present with lower tract symptoms, and the patient will say, I cannot hold urine because it becomes uncomfortable. I have to go. It is not an overactive bladder. It is simply something mimicking like a bladder pain syndrome. But yes, we need to understand that this is also one of the parts of the history. Then if patient has been diagnosed as one of these conditions, then it is quite likely that the patient may be having a kind of bladder pain syndrome, because there's a close association of bladder pain syndrome with all of these disease processes. So when you're examining a patient, we should look at the gait of the patient, because many times, as I said, these patients have dysfunctional voiding. The cause of dysfunction is the lumbosacral spine, which is causing spasm in the lower back, and that spasm is going continuing into the pelvic floor. And because of this, there has turbulence in the trigon. The bladder is pushing, the external sphincter is not relaxing. There is a erosion, there is some kind of inflammation in the trigon, and that is what kickstarts this bladder pain syndrome. So not all patients will present like this. So somebody who is prone to, say, for example, prone to having
What happened, Dr. Arun?
Sir, I think there is a connection issue. First, there was a pause in the presentation, and then suddenly it went down. Probably he may rejoin. I'll just call him, sir.
Okay.
hello, am I audible?
Yes, sir. You're audible, sir.
Hello, am I audible?
Yeah, yeah. Please share your screen, sir.
Okay, so
Hello,
We are hearing you, sir.
hello,
Please share your presentation.
hello, hello.
Navneet? Navneet?
I think he has joined.
Hello.
Yes, Dr. Rajesh.
Yeah, please share your presentation, sir.
Huh. So is it okay now?
Yes, sir.
Hello. Hello. Okay. Okay. So I was talking about, we'll start from here. On examination, as the patient walks, we can see if there is a lower back issue. What is the mental state of the patient? Are there somatic signs of anxiety like pallor, sweating, etc.? Or some scars on examination of the abdomen, scars of the previous surgery, as I said, any abdominal masses, tenderness, any local area of tenderness. That is very important. If there is a suprapubic diffuse tenderness, it's okay. If it is a pinpointed tenderness in the suprapubic area on one side, in a woman, we should look at something coming from the adnexal pathology. Pelvic examination in the female is very important, and it starts with the usual gynecological training that we have been imparted. But the most important thing is when we do a digital pelvic examination, we should look for spastic group of muscles. It is very rewarding because many patients would, if you see them, they are sitting on the chair and they are not sitting comfortably, they are moving constantly. And this is the patient, if you do a digital pelvic examination, you will find that on one side, the levator and eye muscles are tighter than on the other side. And that means that there is a nerve root irritation. And that is not manifested. It is only manifested as a urinary frequency and pain and dysuria. So these things need to be carefully examined. If there is any area of tenderness in perineum, then one needs to exclude a local pathology. There may be trigger points which may be noted. That is on the examination of the perineum. As I said, what I described was a myofascial band. And if there is a myofascial band, you just have to stretch it and that will just take care of it. In case you feel there is a need, you should do a complete neurological examination. But otherwise, focused neurological examination in terms of perineum, inner thighs, sensation, and jerks of the lower limbs must be done in all these patients. So coming to the investigation, the first investigation is a frequency volume chart, which is priceless, because you have to insist that I want to know how much urine are you producing each time. Sometimes the patients will come and tell you that they are going to the washroom every 15 minutes. Then, of course, they are not able to produce that much urine. But sometimes they will say they are going every 1 hour. That is the time you have to ask. Because if they are going every 1 hour and they are producing a glass of urine every 1 hour, then you need to find out, are they producing more urine because they are drinking a lot of water? Many times patients will tell you that in the mornings they go to the washroom every half an hour for 4 hours. And if you ask detailed history, they will simply tell you that we have been taking 6 liters, 6 glasses of large glasses of water the moment we wake up. So where is that urine going to go? So that is how frequency volume chart becomes important. You can differentiate, especially also during the night. If the patient is able to hold urine for more than 400 ml during sleep, then perhaps we are looking at a bladder pain syndrome, which is non-Hunner's, because Hunner's lesions would not allow a 400 ml to be stored at all. So these are the things which we need to pick up from frequency volume chart. They give us a lot of information. Urine routine, preferably the first morning sample. When I say first morning, it means that you should not have taken the bed tea, you should not have taken any water, because that is going to dilute the urine. So just give the first sample midstream before you have your breakfast or water or tea or whatever. That is the first morning. And that will give us a clue whether there is infection or not. There are 3 signs of infection on urine routine examination: the leukocyte esterase, the nitrite, and the pus cells. If any of this is there, that means there is infection. If all 3 of them are absent, that means there is no infection, whatever be the culture. If the urine routine says there is no nitrite, no leukocyte trace, no pus cells, there is no infection. Then a very important test is ultrasound of the KUB area with residual urine estimation. This is very important because we live in a state where there is a lot of stone disease, and lower ureteric stones can mimic bladder pain syndrome, and many times I've been fooled with that. We need to do, if you strongly suspect something, you have to go ahead and do a CT-KOB. Residual urine becomes important because if there is a large residual urine, it virtually excludes bladder pain syndrome because these patients cannot hold urine. So it changes the diagnosis. So it is very important to have this. So coming to what are the various terms that have been used. So I will say that normally patient will present with pain. So you have to know that there is a chronic pelvic pain. And then chronic pelvic pain could originate from intestine, from the genitals, from the urological thing. So you differentiate that if it is related to the cycle of micturition, it is likely to be a urologic pelvic pain. And if it is related to cycle of micturition, then the wider term is a bladder pain syndrome. When we talk of bladder pain syndrome, it means that the bladder appears to be the seat of pain, whatever be the pathology. The pathology can be anything. The pathology can be in the spine, it can be in the nerves, it can be anywhere. That means that structurally the bladder may be absolutely normal on cystoscopy, but the pain is still perceived to be coming from the bladder. That is why it is a rather umbrella-like term in which we included what is called interstitial cystitis. Now, interstitial cystitis is a very specific disease that was described almost 200 years ago, that there was a pancystitis. That means all the layers of the bladder were inflamed. And initially at that time, those kind of symptoms were seen because of bladder stones. So surgeons used to open up the bladder and pick up the stone. Then they realized when they opened up the bladder, they did not find stone, but they found angry, small, contracted bladders, which were totally inflamed, and they called it pancystitis, and the term interstitial cystitis was introduced at that time for that. Slowly, maybe 100 years ago, when we had our cystoscopes coming up and we started looking inside, we found ulcers. And those ulcers were the ulcers which were called Hunner's ulcer because they were described by Gay Hunner in 1915. And perhaps they were the cracks that would occur because there was an attempt to distend the bladder, and the inflamed bladder mucosa would crack and bleed, and they would call it Hunner's ulcers. But they described it very well because Guy Hunner also did an open excision of the ulcer with an open cystotomy. And when they removed the ulcer, the pain appeared to be reduced, only to return and only to have another ulcer coming up. So that was the beginning of interstitial cystitis. But today we know that if there are signs of inflammation in the bladder, we will term it interstitial cystitis. If there are no signs of inflammation in the bladder on cystoscopy, but the pain appears to be related to bladder pain, the bladder, then perhaps it is a bladder pain syndrome. So bladder pain syndrome is a larger diagnosis which contains interstitial cystitis. And I talked about differentiating the urgency, urge incontinence, frequency, nocturia from overactive bladder. And this is a simple way of looking at it, but it is also known that almost 14% of ICBPS patients would also have overactive bladder. So there is an overlapping, there is an overlap. They do not come with fixed scientific diagnosis or scientific symptoms. But the point is that we should be able to differentiate overactive bladder. Absence of pain is overactive bladder. The fear of urge incontinence is overactive bladder. The fear of pain is bladder pain syndrome. So this is very clear. So if you can remember this chart, maybe your diagnosis becomes easier. So we started this movement, and we had our definitions, because every area in the every geographical area had their own set of problems, and they decided to have their way of looking at these kind of diseases, like America, the North America, the Europe, the Japanese, the Oriental. So we had our ways of looking at it, and we realized that the best way to define bladder pain syndrome was the pain or discomfort in the lower abdomen or urogenital area of more than 3 months duration, which is worst on full bladder, along with one or more of the lower urinary tract irritative symptoms like frequency, urgency, nocturia, with or without standard stigmata of cystoscopy. This is important because we're talking about bladder pain syndrome. Interstitial cystitis is part when you have stigmata of bladder inflammation, we call it interstitial cystitis. Even if we don't have the interstitial cystitis, we have bladder pain syndrome, provided another discernible pathology which is likely to cause these symptoms has been excluded. So one of the questions which is very important in the clinic is, if the male patient comes with such symptoms, how do you differentiate it from chronic prostatitis? So I talked about dysuria. So in a male, if the pain starts at the beginning of urination, that means this is chronic prostatitis. So there is no pain. In chronic prostatitis, the pain and the burning sensation starts when the patient starts passing urine. It is chronic prostatitis. And if you look at the other way, if it is a bladder pain syndrome, one of the classical symptoms is that the patient says we would avoid a road journey because if there is a bumpy road, there is pain. And then patient wakes up from sleep due to pain. So all these things are bladder pain syndrome. And on examination, if there is a suprapubic tenderness, it is bladder pain syndrome. If there is a tender prostate on DRE, it is chronic prostatitis. So these are the things, but then really it is difficult to differentiate clinically, but these can be the clues. As I said, when we look at these patients, when do we do cystoscopy? So the ESIC guideline, the European guidelines 2007, they do not talk of duration of symptoms. They are absolutely silent about duration of symptoms. And they talk of cystoscopy and biopsy as part of the workup. So they do not wait for anything else. They have to do cystoscopy, they have to do biopsy. And these are the guidelines adopted by the Europe. And if you look at the AUA 2014 guidelines, they will talk of cystoscopy as a third line treatment. That means they make a diagnosis, they start first line treatment, second line treatment, and then they talk of cystoscopy. So there was a big difference, a notion of difference in the concept of Americans and the Europeans. And that is why we needed in India to have our concepts clarified. And we realized that cystoscopy should be done early on, not in the American system, because even though it is not essential for diagnosis of ICBPS, it will exclude a lot of pathologies, and also it will keep the medical legal threat much lower down. We have been seeing patients who have been diagnosed as interstitial cystitis or bladder pain syndrome being treated in our country, and they've finally gone to another urologist after a year or so, and somebody had to do a cystectomy because it was a CA bladder, and somebody had to do augmentation cystoplasty because it turned out to be tuberculosis. So cystoscopy is, even though it is not essential for diagnosis of RCBPS, it is essential to exclude other disorders. And therefore, cystoscopy in our guidelines that we started, we keep it just before we start treatment. We have to make a diagnosis, and for that we need a cystoscopy. It should never be done under local anesthesia. The patient is struggling, the surgeon is struggling, so it must be done under general anesthesia. It is because the bladder is inflamed, and if you are trying to fill it, and it is going to cause pain, and the pain is coming from the detrusor. the nerve endings which are there in the detrusors, not in the mucosa alone. So when you give local anesthetic agent, you are only anesthetizing the mucosa, but the bladder, the detrusor muscles, whatever the nerve endings are there, they are the cause of pain. And if the patient is not allowing you to distend the bladder, so you will never be able to see what is inside the bladder and you will miss the diagnosis. And initially, if the bladder is small and you just put in the scope and come out because bladder has not been distended, it may just appear to be normal. And you do a great disservice. There's a patient who has been suffering, and eventually, after say 5-6 years, the patient has reached a urologist. Urologist has done a cystoscopy under local and reported normal. That means you have sealed her fate, because her family is going to think that now that the urologist also has seen this patient, and this patient has absolutely normal bladder, that means this patient is just seeking attention and she is actually a troublemaker in the family and not suffering. So never do that. Never write a normal report only based on the cystoscopy under local anesthesia. Moreover, if you find a Hunner lesion, or if you think that the bladder is small and you need to do hydrodistension, you should have a complete relaxation under general anesthesia, which may not be possible under local anesthesia. This is a typical Hunner's lesion. So you see there is a pale center with parallel radiating capillaries, and this is a classical Hunner's lesion. We shifted from Hunner's ulcers to Hunner's lesion because we realized that they were not true ulcers. They were actually lesions, and when we would distend this, they would crack, and then they would be looked at as ulcers. So this is how there may be a mark of fibrin deposit at the center of the pale area, and in this picture you can see perhaps it is about to rupture and form an ulcer while we are hydrodistending this bladder. These are glomerulations. So these are diffuse glomerulations, but diffuse glomerulations do not qualify to call it a interstitial cystitis. That is because this can occur in a variety of diseases like radiation cystitis, like drug-induced cystitis, viral cystitis. Now these are chronic fungal cystitis, chronic bacterial cystitis. One of the classical things, if you go back to this lesion, you see that even though there's a Hunner's lesion here, the rest of the mucosa is normal, absolutely. So intervening mucosa is normal. But if you see glomerulations, the whole bladder is full with glomerulations. So these glomerulations are small capillary, telangiectatic capillaries, and they fill the whole bladder. So then we do not call this an interstitial cystitis. We know that there's an inflammatory pathology of bladder, that is all, but we will not call it interstitial cystitis. So again, when the bladder is being filled and is deflated, you will find bleeding. This is raining of blood from the Hunner's lesions. And this can also have petechial hemorrhage. Again, these are glomerulations because they are distributed randomly all over the bladder. These are not Hunner's lesions. They are not specific for interstitial cystitis. So we must do a biopsy because primarily to exclude other pathologies. We have seen so many pathologies, and it is sometimes rewarding to find a treatable pathology, and that is why biopsy is must. We must do a hydrodistension before the biopsy. If you want to do a biopsy and hydrodistension, never do the biopsy and then distend. Always distend first and then do the biopsy. So summary of diagnostic tests. So we talked about history, we talked about examination, we talked about role of cystoscopy, and we are about to make a diagnosis. So for the diagnosis, I'm going to write that this is the mandatory steps are history, examination, frequency volume chart, urine test, ultrasound, cystoscopy, and Sometimes you may need a urine culture, especially if urine analysis shows pus cells or signs of infection like leukocytosis or nitrite. Then you go for urine culture. Then urine cytology in case there is history of hematuria, and of course symptom scores. Now symptom scores are important because if you are following these patients and you are keeping a log, then you would know that okay, this is the symptom score today, and after treatment the symptom score is that different. So what we generally do, and it is not followed in India but in many countries where patients want to do something like this, the scoring is done by the patient and the nurse outside the clinic of the patient, of the doctor. So when the patient walks in with the score, and the doctor asks, how are you feeling? The patient may not be able to assess and say, okay, the patient may simply say that I have not improved. But if you look at the score chart may have improved. So then you can explain to her that, okay, these are the areas which have improved. These are the areas which have not improved. So symptom scores become important in certain biofeedback kind of a thing. If the symptom score has improved and you can convince the patient that, look, this is what is happening, it acts as a biofeedback. Sometimes patients will say, हमें कोई फर्क नहीं पड़ा, we have not improved. But then you ask, okay, how many times did you wake up last night? So they will say, I woke up only twice. So how many times were you waking up earlier? So I was waking up 6 times. So there is a difference. The patient may not perceive it in the first go, but then you have to understand that, okay, it only means that my diagnosis is correct, that my treatment is going to be correct. It is going to take time. It has started taking effect. It has not affected completely, but it has started taking effect. And of course, others are quality of life scores, which are only for research purposes. We do not expect them to be done by routine urologists in practice. PSA, one should not forget, if somebody is in that age group, in a male patient, we must do that because it becomes your responsibility. Patient has been coming to you and you have not done PSA, you have missed a diagnosis that may not be pardonable in any law. And of course, there's something called lignocaine test. So what happens is that the patient has come with pain and you are not able to decide whether it is coming from the bladder or is it coming from the colon or whether it is coming from the uterus. Then what we do is we instill. I think that somebody needs to mute the mic. Somebody needs to mute the mic. Somebody needs to mute the mic. Somebody, Dr. Sai Swarup Yamajala, you need to mute your mic. Dr. Sai Swarup Yamajala, you need to mute your mic. Yes. So thank you very much. So lignocaine test. So when if the pain is coming from bladder, colon, or uterus, how do you differentiate? So what we do is we pass a thin infant feeding tube into the bladder and instill 20 ml of 2% lignocaine and wait for 10 minutes. If the pain is coming from the bladder, it disappears completely. Now, why this started was because initially by Paulson, there was this test called potassium test, potassium sensitivity. So they used to put in a molar solution of potassium chloride into the bladder and the patient would jump with pain. So I thought, why to give pain to these patients? So we devised lignocaine test, which was published. And urodynamic study. In case you think there is a voiding dysfunction, the patient says, I have a desire to pass urine, but I cannot pass urine. I keep sitting there. This is perhaps the patient who requires a urodynamic study. Coming to the etiopathogenesis, because this is a theory class, so I thought I will include etiopathogenesis into this. The basic idea is that there is a bladder insult which could occur due to any kind of inflammation, autoimmune disease, bladder over distension or pelvic floor dysfunction or bladder trauma, and there is a damage to the epithelium. Once the epithelium is damaged, which is the urothelium, which is a very sensitive organ in the bladder, there is leakage of constituents into the interstitium, especially potassium rich constituents. And that causes activation of mast cells and histamine release, which causes a progressive bladder injury. Now, once the mast cells are getting activated, the C fiber can get activated and there is a release of substance P. And if there is an immunological or allergic response, that also activates the bladder cell. So as I said, we during our history taking, we try to find out if there is history of allergies or history of something like neuropathic pain. So we can actually find out which one of these pathways is working in a given patient. This is the normal bladder. There's a bladder lumen, there is a gag layer, glycosamina glycan layer, which is above the epithelial cells. There are tight junctions so that the bladder, the constituents of the bladder, which are hypertonic, they don't move into the interstitium. But if there is a damage in the gag layer or there is damage in the interpursing cells, then the constituents of urine can pass through and cause inflammation in the interstitium. This is the pathogenesis of interstitial cystitis. As I said, the irritating solutes will just pass into the interstitium. The nerve endings are there and they get irritated and they can give rise to pain when inflammation is continuing. So this is the, in nutshell, the pathophysiology. There is a bladder insult, which may be perhaps chronic infection or whatever, as we discussed in the earlier slide. And there is epithelial layer dysfunction because it gets damaged. There's a leakage of constituents, activation of C fiber, mast cell activation and histamine release, which causes more injury. This injury is going to increase the damage in the epithelial, and the epithelial dysfunction increases and the patient goes into a vicious cycle. Sometimes the patients come to us in a very late stage. The bladder, uh, the bladder volume is hardly 30 ml or 50 ml, and you cannot retrieve or do anything more than that. Then, when we talk of etiopathogenesis, this is the local bladder pathology, but then there could be other non-bladder pathologies like overactive pelvic floor, central nervous causes, stress causes, autonomic nervous system problems, and past experiences, which may be traumatic experiences in childhood. Or there could be a crosstalk between a leaky gut and the bladder urothelium. So there is maybe, for example, nowadays there is this gut microbiota, which has taken a lot of attention, and that causes a lot of inflammatory pathology in the gut, small and large intestine both. Now these kind of inflammatory things, if there is a signal which is mixed, the brain perceives that it is coming from the bladder rather than the bowel. So there can be a crosstalk between the two organs, the large intestine and the bladder. How do you manage these patients? The most important thing is that you need to have a proper way of breaking the news to the family. It is very important to involve the family. You simply cannot have a patient and you treat the patient. You have to ask the patient to get all the family members. More often than not, the family member, one or two, are always there who are near. But you need to educate them and tell them, look, this patient has a disease. This disease has been understood. And this, and because they will say that a lot of doctors have told us that it is all in your mind. Then they have been referred to psychiatrists, they have gone to the faith healers, and they've gone to alternative medicines. So then these patients need to be told and their families need to be educated about the disease. I generally tell them, because many of them are very well read, I tell them, go and Google this disease, read about it, come back and speak to me again. Because unless you know what this patient is suffering from, you will not be kind to this patient. And you have to tell them it is not a taboo, it is treatable, and we need to work as a team. So, as I said, we need to categorize these patients because this is a bladder pain syndrome. Simply writing bladder pain syndrome and writing a treatment is not going to work. You have to categorize, you have to understand what is the etiopathogenesis and what exactly is going wrong with this particular patient. So as I said, if we have an idea about the etiopathogenesis based on the history, we should be able to find a solution for individual given patient. So as I said, clinical scoring system, I've already talked about. Now, the pain is the most important symptom and must be respected. So for pain, we should do everything to reduce the pain. As I said, if you can give amitriptyline or gabapentin with nortriptyline combination, that should be given because pain is the first thing that needs to be addressed. Of course, the rest of the things are not unimportant. The first, but you have to tell them the first thing that I'm going to do is to relieve your pain. This frequency and nocturia is going to be the next, and subsequently we will have the other things addressed. So how do we look at the treatment? So this is the same, I brought the slide, which is the etiology, etiopathogenesis of IC. And we need to have multimodality treatment because there are multiple levels in which we can interfere. So for example, if there is a bladder dysfunction, a bladder urothelial dysfunction, we need to do something to repair the epithelium of the urothelium. We also need to do the modulation of the neuronal activity because, as I said, C fibers are exposed and they are actually firing without a reason sometimes because they are exposed and they are irritated. We need to modulate the neural activity because there is also neuropathic inflammation. We all know that there is inflammation which causes pain, but in IC, it is the pain that causes inflammation. So there is a retrograde or what is called antidromic conduction of the neurotransmitters which cause inflammation. So the signal of pain goes from the C fibers, and then there is an antidromic conduction and release of neurotransmitters, pro-inflammatory neurotransmitters in the bladder. We call it neuropathic inflammation. So it is the pain that causes inflammation. Then we need to stabilize the mast cells because the mast cells appear to be the final pathway through which the pain and inflammation is occurring. So for repair of epithelium, urothelium, there is an oral medication called pentosan polysulfate. For the modulation of the neuronal activity, it is tricyclic antidepressants, the amitriptyline. And for stabilizing the mast cells, it is antihistamine, the hydroxyzine. So this is how we handle a given patient because there is multiple levels of intervention which are required. And still, if there are symptoms which are similar to overactive bladder, we can use some kind of antimuscarinics. But there is a warning about antimuscarinics. If you give an antimuscarinic and you paralyze the bladder, the patient is going to be miserable because the patient has now a distended bladder which is causing pain, and the patient is not able to empty the bladder, and the pain is continuing. So this one needs to be qualified further. So as I said, we have treatment modalities. We start with oral non-specific medications like gabapentin, hydroxyzine, amitriptyline, and as I said, tolterodine as antimuscarinic. But I will give you a caution if the patient has paralysis or detrusor hypotonia secondary to antimuscarinic, it is a very distressing situation for the patient. Then sometimes in patients who have dysfunctional voiding or discoordinated voiding because of overactive pelvic floor, you need to give skeletal muscle relaxants like clonazepam or chlorbenzaprine. Then we have the next group, which is the specific oral medication, which is pentosan polysulfate. It is known to replace the gag layer of the bladder, and it is the only oral definitive curative treatment which has been approved by the FDA of USA. It has to be given 100 milligrams 3 times a day, but has to be given before meals. So it has to be given at least 1 hour before meal on a empty stomach which has been empty for at least 2 hours, because Otherwise, the absorption is jeopardized. The effects may not be visible for the first 3 months, but if you are using it in the right patient, you will be rewarded. And this is the only long-term gag replenishing oral treatment that we have. The side effects include GI upset, rectal bleeding, alopecia is troublesome. And now recently, there is something called maculopathy. Maculopathy has come up in the last 2 years, and it has been reported in the United States of America that there is something called a pigmentary maculopathy, which has been seen to be associated with use of oral pentosan polysulfate for more than 10 to 12 years. We are still investigating whether there is a causative relationship or not, but as of now, the warning has to be put on all oral pentosan polysulfate packaging that there may be a risk of pigmentary maculopathy, which is progressive after you stop the oral pentosan polysulfate. The only thing is, as of now, we know that it is for long-term use of pentosan. So maybe 10, 12 years, 13 years of pentosan, and then that is how it works. So if you want to know more about oral pentosan polysulfate, this is a recent article and this is available. If somebody wants it, I can send it to them. You can contact me for this article. Then the treatment continues. We have intravesical treatments, which can be cocktails of gag layer replenishing. In Europe, we have chondroitin sulfate and hyaluronic acid. In India, we use our cocktails. One of them has been published under my name, and it contains hydrocortisone. It contains heparin. So heparin and hydrocortisone given in patients weekly in a 40 ml solution weekly for 6 weeks has a very good effect, provided cystoscopically you have seen that there were Hunner's lesions which you would have ablated anyway, and then you can give you can give intravesical treatment once a week for 6 weeks to supplement the cystoscopy, hydrodistension, and ablation of Hunner's lesions. Systemic steroids do have a role, especially if patients cannot come for intravesical treatment and there are flare-ups, but then they have to be cautiously used. You cannot use simply to all these patients. Cystoscopic hydrodistension is again very important. As I said, if you have a patient who has Hunner's lesion and a small capacity bladder, this is very rewarding. So if it is done properly, it has very good immediate effect. The only problem with cystoscopic hydrodistension is that the symptoms would recur in maybe 6 to 8 months time, and sometimes you have to repeat them. A lot of patients would come back within a year, and you may consider repeating them. And when you're repeating cystoscopic hydrodistension, you may find recurrence of Hunner's lesions which require TUR. So this is the graph. You start with oral non-specific medication, go on to the specific oral medication. You must do a cystoscopy and hydrodistension and ablation of Hunner's lesions, and follow it with intravesical treatment. And in case you are stuck and the bladder capacity is falling, you may use systemic steroids. Diet has a major role. We tell them that you identify what is causing the flare-up. So sometimes people will come up and say that if I have a Chinese food, then I would always have this pain. Somebody will say if I have mangoes, I will have this pain. So there is a role of diet, because all the metabolites are going to be excreted through the urine and the bladder is going to store that urine. So we need to know what is hurting which patient. Unfortunately, it is not easy. There may be many patients who would be happy with one kind of diet, but the same diet would be adversely affecting the other patients. So we encourage patients to have their own diet charts. They enroll into groups. They keep talking to each other, and they look up at IC help websites, and they contribute to one another. So they write their own experiences. In today's era, we have WhatsApp group of our patients, and they communicate so much to each other, and they pick up hints that okay, this is what could have been hurting. So what the recently that I learned was that sweets like rasgulla, which has a lot of syrupy sugar, even that hurts certain patients, which sometimes is very difficult to imagine. One could have never fathomed that, but then through the patient group we realize that that is also happening. Pain management: if you are not able to handle the pain, you should have a physiatrist or somebody who manages pain. And sometimes we have given impar ganglion blockage for pelvic pain, which was related to bladder and had some good results, even though temporary. Physical therapy or physiotherapy for patients who have overactive bladder, overactive pelvic floor. So if patients have overactive pelvic floor, then physical therapy is must. We start with muscle relaxants like clonazepam, but we must also have dedicated physiotherapy for pelvic floor relaxation exercises. The biggest problem is you send them to physiotherapy department and they come back with Kegel exercise. Kegel exercise is further strengthening the pelvic floor. We don't need to strengthen the pelvic floor. We need to relax the pelvic floor. So we must have a properly trained physical therapist who understands what we need. We need, in all probabilities, relaxation of the pelvic floor. So to summarize, this is the evaluation protocol: history examination, urine routine, cytology, ultrasound. If in doubt about diagnosis, intravesical lignocaine test. This is the reference. You may have a clinical score and a scale. You must do a cystoscopy and biopsy. And if you find a Hunner's lesion, you should ablate it. And the treatment protocol starts with education and counseling of the patient and the family about the diet modification also. Discuss the options, treatment as per severity, as I have just explained. And I use oral and intravesical treatment. Oral treatment, all these patients get benzoyl polysulfate along with hydroxyzine in case there is history of allergy, and tryptomer or amitriptyline in case there is a neuropathic element in the history, followed by intravesical treatments. And this protocol has been published in 2007, and you have this reference. If there is a relapse, because sometimes patient will 500 kilometers from my place, and if there is a relapse, they will call me. I ask them to get a urine routine and culture and exclude an infection and take an injection triamcinolone 40 milligram intramuscular. And that is what, if it relieves, that saves them the botheration, but they have to come back. But while they are waiting to come to me, their symptoms would be subsiding. And of course, if there are Hunner's lesion, we must do an electroablation of all the Hunner's lesion. And these are the two books which are available. In case any of you are interested, you can contact me. They are very cheap books in terms of price, but in case you cannot find, and if you want, you just have to write or drop a mail, and I will see that somebody can organize them to be brought to you. Thank you very much. I think I have already spoken for more than an hour, and I would be very happy to answer any of the questions that any of you may have by now.
I think in the chat box, I don't have any question, but we'll take the questions if residents have any doubt. You can unmute yourself or you can put on the chat box if you have any question. Prashant, Shruti, if you have any question for Dr. Rajesh.
No, sir. No, sir.
So, in nutshell, one very important thing that I want to speak is that after this class, do not go and start diagnosis ICBPS, because once you have a hammer in your hand, everything looks like a nail. So you must keep that in mind, that that thing exists, because so many times I get patients who have been diagnosed, treated as ICBPS, and they have something else, and they come to me, and I feel bad because these are the people whom I have taught how to treat or diagnose ICBPS, and they have unfortunately diagnosed somebody over diagnosis, what we call, who did not have this disease. So we need to be a little careful. It is important from your perspective to understand the disease. Don't stop here. You should go and read after this, because this is a clinical. The idea of this class is to give you a practical orientation of the disease, because if you have a practical orientation, going back to theory becomes easier, and the theory then fits into your brain much faster that way.
Question from the chat box, which has come now only. Please repeat the cocktail regimen you follow. And Dr. Rajesh, if you
Okay.
can
Yes,
explain
yes,
again
yes,
the
yes,
cocktail.
yes, yes. I actually, there is that paper also that is there. I will give you that. The regime that I follow is 40 milligram, 40 ml of normal saline. That is the volume of the solution, is 40 ml of normal saline. In that you have 25,000 international units of heparin. 25,000. So it is 5 ml of heparin, 5,000 ml, 5,000 units per ml. So 25,000 heparin, 200 hydrocortisone. So 2 injections of 100 milligram hydrocortisone in total of 40 ml of normal saline solution. And we put a small infant feeding tube into the bladder, empty it, and then instill this solution into the bladder and ask the patient to hold as much as possible. The only thing is that every time I'm doing this, I ask the patient to get a urine routine a day prior to this, because if there is an infection, I should not be putting in steroids. So every time the patient comes to me for an installation, she should have a urine routine examination a day before, and there should be no sign of infection before that. I hope that is clear.
Yeah. It's another question. Which painkiller you can use in this
Yeah.
condition and what dose?
Yeah, so the painkillers that I use, the first one that I use is a tryptomar, which is 10 milligrams. Now, tryptomar 10 milligrams can be given at bedtime to start with, and tryptomar can be increased to 25 milligrams at bedtime. The only problem with tryptomar is that it can cause sedation, and some patients may not like sedation at all. Some patients, it is overwhelming. So you need to give, instead of amitriptyline, you need to give nortriptyline. So there is a very good combination of gabapentin and nortriptyline, which is gabapin NT. So gabapin NT is a drug which is used by orthopedic surgeons routinely for neuropathic pains. Now this is the best painkiller that I have realized for these kind of patients.
There's another question from Saurav. Uh, any relation with pregnancy of this condition? If
Yes,
present, and how to evaluate?
yes, yes. So obviously you seem to have missed the first slide there, because when I started this case, I described, and that is why I described the scenario, because it completely defines the PPS, that if there is pregnancy, somehow the disease symptoms disappear completely. The patients go into remission. There would never be pain. But only thing is that when the pregnancy is over, the child is almost 6-8 months, the patient starts getting symptoms back again. So we really do not know why this happens, but in pregnancy, the interstitial cystitis bladder pain syndrome goes into remission.
Uh, I think one more question. Anti-muscarinic. Which anti-muscarinic you use for this? I think this also you have heard, but they want you to repeat.
Yeah. So tolterodine is the anti-muscarinic, which is reasonably well tolerated in these patients. And the advantage with tolterodine is you have it in 1 milligram, 2 milligram, and 4 milligram. So you should start with 1 milligram. Do not start, because if the bladder refuses to empty, then the pain is incessant. You will have to catheterize even at 50, 60 ml bladder, which is very painful. So I think you should, tolterodine, I think, is good choice to start with, because it starts with 1 milligram dose and you can go up to 4 milligrams.
I think there's a question from Dr. Rajiv Sud only. If there are no receptors have much role, how can you explain pain causing inflammation? Any relation with this?
So,
And no receptors.
This is NO receptors. It is the pain causing inflammation is an antidromic phenomena coming from the detrusor nerve fiber. So this is different from the NO receptors. So NO is only in the urothelium. NO is only in the urothelium, but what is happening is that if you look at the nerve structure, there is a receptor at the mucosa, urothelium, and then there is another limb of the neuron which is originating from the detrusor, because detrusor takes the sensation for stretch and sensation of fullness, whereas the mucosa will take sensation for the pain. So if there is pain, it goes into the dorsal nerve through this, but then there is an antidromic conduction through the limb which is going into the detrusor, and there it activates the mast cells and causes inflammation. This is the theory that they say. So there's an antidromic detrusor limb of the neuron. The mucosal limb carries the pain, and the detrusor limb, there is an antidromic conduction, and that causes inflammation by release of the histamine rich cells.
Dr. Taneja, there is a definite component as the vascular component in any inflammation. And NO receptors are not only on urothelium, they are in the microvasculature also, in endothelium also.
Yeah.
Can you correlate some relation or any study?
Yes. So there has been a study from the Sweden. So what they did was in Gothenburg, there's a study from Magnus Fall group, and they came up with the idea that how do you diagnose? So they were actually trying to diagnose, and they found that this nitrous oxide concentration was very high, and they correlated it with the incidence of Hunner's lesions when they did cystoscopy. So there is a definite correlation. It has been documented, and the study came in 2005. And the first author was Logaditer. She was a student of Magnus Paul. So they did a very good study. Only problem is that we cannot reproduce that, because that required a particular system apparatus to measure the nitrous oxide levels in the bladder. So it is not practical for clinical use, but it is, yes, it is certainly a scientific study. And as a basic science study, that's a very good study.
Dr. Taneja, we have to caution all the people for management, because left and right Kegel's exercise are advised, and that is very important, that when this condition is confused and not diagnosed and you start Kegel's exercise, this will deteriorate.
So I will tell you that I have had so much problem with the physiotherapists in my part of the country, where I would keep telling them that I need pelvic floor relaxation, and the patient will come back with Kegels. So last year in January 2020, I had a visiting faculty from US, and we had a workshop on physiotherapy, and I collected almost 100 physiotherapists from Delhi NCR region, including the Department of Physiotherapy at Apollo, and brought all my patients of interstitial cystitis, and the visiting faculty taught everybody how to do. So we had a complete hall in which she described the exercises, and the actual hands-on training for the physiotherapists as well as patients was given. So it is very important, and that problem is a real problem, not only in India, in many places across the world.
I think there's no more question on the chat box. Like this was very interesting class. I think the subject is not very well taught in the readiness training, and but at the same time, you always get some question in the form of short note or a long note in one of the four papers of DNB or MCH. But the way you have nicely I think split the very neatly split into different sections, right from case to etiology to the treatment of different line of treatment. I think it was very well described. I don't know whether agents have taken a note of how you have nicely brought the cystoscopy from the third line treatment to somewhere in the forefront, where not only it acts as a diagnostic modality to rule out other causes. It acts as a what you can say a confirmatory for the diagnosis as well as the therapeutic also. I think the agent should make note of how to make use of the investigation you have, and at the same time, a very nice point you have made that about how the tuberculosis, how the stone, how the AAP, the people being diagnosed as this for long and long, and maybe having something else like BP and IC. I think I'm very confident at the end of this around 70 to 80 minutes of this lecture, there will be much clarity, and probably when they are seeing the patient of this type of symptoms of a long-standing duration, they'll be much wiser in making their list of differential diagnosis and obviously keeping this BP and ICS in contention. Um, uh, at the end, I'll just invite Dr. Rajiv Sood, Chairman, Indian School of Urology and USI, to propose the vote of thanks and close the session. Over to you, sir.
Thank you, Dr. Arun Chavla, and big thanks to Dr. Rajesh Taneja. Such a clear thought and such a wonderful lecture, rarely witnessed, and we are proud of you as faculty and those delegates and residents who have attended. I think they are now educated for their theory, for their day-to-day practice, and also their vision will be more of methodically, if any diseases to be studied and diagnosed, that is also taught, not only for interstitial cystitis, but for most of the diseases where difficulty of diagnosis is there. I'll mention only one thing at this stage, that this is a perfect case when such patient comes to you, that how to make the provisional diagnosis, then go for the differential diagnosis, and then clinch the final diagnosis. And this is the process which is expected from the residents in the exams, and also in the clinical situations when misdiagnosis is not done, as Dr. Arun Chavla also has mentioned, quoting Dr. Rajesh Taneja, that I myself have seen that when we were doing trials on overactive bladder, not on interstitial, we missed initially. It is 2 decades back, and because we were told that only voiding diary is needed, cystoscopy is not needed, and we diagnosed mild strictures, early tuberculosis, a very small stone in the vesicle stone also, and also the malignancy. And especially Dr. Rajesh Taneja has very well commented that diagnosing interstitial cystitis or painful bladder syndrome, cystoscopy may not be that important, but it has definitely role when you are going from provisional diagnosis to differential to clinch the diagnosis. And ultimately, the way the things have been made clear is he has authored the books, he has contributed in the Indian guidelines, and we have been also USI is also associated with the society which is floated in the name of Gibbs. And I remember the Kochi conference when this topic was discussed 2 decades back. then we were thinking that what is this topic and what is being taught, because we were not caring for this topic. And these subjects, this diagnosis has become very important. It is not a rare disease. It is not an orphan disease. It is a disease which is prevalent but not diagnosed or misdiagnosed. So thank you very much for this wonderful session. And also, this is going to be archived for times to come. You can go again and see, and you can listen, watch on in the USI archives this lecture, which is going to be beneficial for all those who have attended, all those who have not attended, and also for the consultants and the practitioners of this syndrome, this disease entity, and urology in future. Thank you very much. Good night. Thanks to
Thank you,
everyone.
sir. Thank you very much.
Thank
Thank you, Dr.
you.
Rajesh. Thank you, Dr.
Thank
Rajesh.
you. Thank you
Bye.
very much. Thank you.